خلي سمراء تتألق.
متألقة متألقة بس حريت شوية.
دائما دائما ما شاء الله.
We are on, guys.
Okay. Okay. Assalamu alaikum جميعا. It's our pleasure today to have the first SASM pediatric session through the Zoom, and we choose one of the very important topics that usually is common in the pediatric emergency, but for a reason or another, either we don't diagnose it or we don't give it the attention. So I think psychiatric emergencies is very important point. We are going to have highlights about the most important psychiatric issues in the pediatric emergency room. Dr. Samra, she's Samra Ahmed, she's a psychiatrist, assistant professor at King Abdulaziz University Hospital. We are very glad to have her today. She is going to give us short notes, although she is very busy time, but we would like to thank her for her time, and also we thank all the supporting teams, Dr. Roa Jamjoom, Dr. Arim. They give very big support to start and initiate this very important topic and session. So welcome, Dr. Samra, and you have the mic.
Thank you so much for the introduction, Dr. Bandar. Thank you so much for the invitation. Assalamu alaikum wa rahmatullahi wa barakatuh. الصلاة والسلام على سيدنا محمد وآله وصحبه. طيب, I feel I got tricked because دكتور بندر أنا سألتك كم المتوقع عدد الاتندنس participant. You told me somewhere like 30 or 40.
Yeah, ما شاء الله. Yes, now see how much we have.
حاسة إنه انضحك علي. طيب, so أنا فاتحة الشات وفاتحة ال Q&A. I'll try my best إنه أطول فيها. I like the lectures to be sort of interactive as much as possible. نخليها interactive. So if you have questions or stuff on the side, I'll look at it. Dr. Bandar or Dr. Roa, if there is something very specific, please just write it down and I can do it in Q&A.
Okay.
I usually speak a little bit too fast, so ask me to slow down if I'm too fast. So now let me share the screen. عندكم screen?
Yes, yeah, Dr. Samra, go ahead.
Yep, it's showing.
You can see the slides?
Yes, clear, thank you.
Okay.
Yes.
طيب, so psychiatric emergencies in children. So I am super happy that we're not talking about COVID. وأعطي الفضل لCOVID and we got invited, otherwise we never get invited. طيب, I'm sure you got sick and tired of COVID. إيش نسوي إيش نسوي? You cannot talk about cupcakes. So good, you know what? Let's talk about psychiatric emergencies in children. So you know what? We might not be your first choice in terms of lectures, but we're still thankful. Now, like, when do you call a psychiatrist? The thing with calling a psychiatrist, I'm going to start with a very quick story. والدتي كانت مديرة دار أيتام, so I worked a lot with troubled children and kids with psychiatric disorder since a very young age. And this is actually why I wanted to do psychiatry and child psychiatry specifically. Now, this is the kind of story I'm going to go for interview أقولها because it makes me look good. Now, the other side of the story, I like psychiatry because of lifestyle. Okay, so emergency medicine is the opposite of whatever I want to do in my life because nobody wants to do like mashallah يعطيكم العافية that intensity of emergency. So هأطول في الشات على السريع. لو سألت كده على السريع, when do you call a psychiatrist? طيب هذه مختفية. So the answer to this question is never. You never ever call a psychiatrist. طيب. Child psychiatrist is double never. We have no business, honestly, being the emergency medicine, ERs or ICU. So yes, there are cases that we should be called, but how بقدر المستطاع to have that idea of مخكم. We don't call psychiatrists for the emergency room. Now, please focus with me, because if you really got this, your chances to call us حتقل مرة كتير. You'll be happy and I'll be happy. Now, الأجندة حقتنا, we're going to understand a little bit of the intersection between social, psychological, psych, and legal aspect. لأنه أحيانا كتيرة we get called على حاجة has nothing to do with psychiatry. It's more of a psychology thing or more of a legal aspect. هتكلم a little bit of limitation of a child confidentiality, because the legal aspect will rights حقت الchildren's مو دائما well understood or protected. وبعد كده هأدخل على التوبيك حق المحاضرة اللي هو top psychiatric emergencies. Now, as I said, الفيلد حقنا is very tricky. يعني حتى child psychiatry أكثر من adult psychiatry، لأنه في legal aspect له، في social aspect، في medical aspect، and طبعاً في social aspect to it. Now, I'm going to start with these cases. I actually can't see the chat, so have minimize this, more chat. طيب. Yes. Suicide, thank you. Yes. Rule out medical issue. هل في شهادات حضور؟ That question is so offensive. It makes me feel I'm so boring لدرجة الناس بتسأل طب at least هناخد شهادة حضور. Anyway, let's start with this. 17-year-old female jumped off the second floor of her building because of exposure to domestic violence. What is this? Psychiatry, psychology, social, medical. I mean, let's assume she's medically cleared. أي أحد يكتب لي forensic what؟ لأنه في forensic وفي forensic psychiatry. Okay, so it's very complex, because when you think about psychiatrists, we do medications. I'm going to give a medicine. This is a person who's exposed to domestic violence, okay? So me coming to the ER, I'll evaluate for suicidality, but I'm not going to fix the problem. So this is kind of complex. It makes the ER physician very frustrated, because we're going to come to the ER and we're not really resolve the problem. Harm suicide evaluation, but not going to be very helpful acutely. Second, 9-year-old child presented with depressed mood, multiple scar, recent hand fractures, and evidence of an old heel fractures. What do you think of? Yes? You think about abuse. طيب. Now, الناس اللي قالوا psychiatry, طيب حأجي على ER, there is a child who's being abused. Now, try to be in my position. What am I gonna do في ER? As a patient عنده multiple fractures, some of them are healed, في bruises, في مثلا cigarette شو اسمه thingy هنا. What am I gonna do? Now, it's very tricky. I can evaluate. Okay, thank you. أحد كتب report. Okay, it's very complex. Now, I'll tell you how ER people think. Okay, so from an ER perspective, again, in such a cases, yes, we should be involved, but we're not the first liner. لأنه أنا ما راح أعطي دواء، ما راح أسوي therapy. This is a patient فيها طبعا legal aspect. An 8-year presented to the ER because of history of sexual abuse. Okay, I said, what is this? Who do you call? Now, all of you, yes, absolutely legal, the police أول شيء to be contacted. But a lot of you can بتكلم على admission, forensic, few days مش عارف مين, okay? You don't have these services في ER, and a lot of hospitals, they don't have a well-structured system where I can admit a child safely to a unit متخصصة للأطفال. So majority of these people you need to admit, you cannot admit. So you have to understand why our hands are kind of tied when it comes to helping you. على السريع, confidentiality, domestic unit, I agree, but again, resources limited, and system is not 100% well structured. Now, a child cannot consent for treatment. Okay, this is the basic thing. أنا ما أعرف أحد بس يكتب لي لأنه I noticed إنه من مستشفى لمستشفى يختلف. What is the pediatric age group? إلين كم؟
احنا عندنا 14 دكتورة.
14. طيب 14 هذا على حسب وزارة شو اسمه وزارة الصحة. الكتب اللي بتدرسوا فيها إلين فين؟ What is the pediatric age group? Okay, so
18.
why طيب لما تقرأوا نيلسون، لما نقرأ إحنا هاريت لين، لما تقرأ whatever the book that you're going by, we're talking pediatric age group is until 18. So for legal logistical aspect, it is 14 عندنا, but the truth is until 18. Now, a patient who can't consent for treatment, الconfidentiality حقته limited. Now, a standardized form بالنسبة limitation of confidentiality, you don't have to disclose كل information للأهل, but if it came to abuse, sexual abuse, and again أحيانا كثير الناس اتلخبطوا because 18 ممكن تكون واحدة متزوجة 18. Remember في few cases within the system ايش يسموها لما يكون احد 18 سنه او 17 pediatric اذا متزوج او بيشتغل, what do you call them؟ احد يعرف؟ emancipated, so it means he can be treated as an adult, child bride. Yeah, it is a child bride. ما أعرف ليه فكرتيني بفيلم تشاكي, but this yes, emancipated. So this is the term. So he can be treated as an adult, but other than that, they're all going to be treated as pediatric. Sexual abuse, physical abuse, أي حاجة endanger their life, you can break that confidentiality. Adolescents, yes, but it's pretty much the same rules and regulation حقت الأطفال. Top emergencies, suicide, agitation, extrapyramidal symptoms, neuromalignant leptic syndrome, serotonin syndrome. هل في شيء أكثر من كده بتشوفوه في الإي آر؟ Anything I missed? Okay. طيب, psychosis, yes, but psychosis ممكن تتحط تحت agitation. Because generally you're not going to treat psychosis. You're going to treat agitation because remember it's an ER. Now, emergency for a pseudo seizure, deliberate self-harm. Okay, good. So we'll cover all this. ما حتكلم على anxiety, ما حتكلم على depression, panic attack, because pretty much you know how to deal with these and you would rarely call us for it. My apology if this is something you would have wanted to hear about. But for emergency, interendocom, 3 decisions that you have to make, okay? Save a life or an organ, admit or discharge. This is what you want. End of the day. امسك طبيب الطوارئ, ارفع سماعة التليفون. They want to know one answer. Admit, discharge. Sometimes treatment, but majority of the time that's not the purpose of an emergency. But you know, sometimes الله يجزاكم خير you consider treatment. نتكلم عن الsuicidality. Suicidality لها a huge legal aspect. Now, the legal aspect of it, any suicidal patient or any suspiciously suicidal kid, you have to call the police. Now, can anybody ask me why do you have to call the police for a suicidal child? And I don't know. I don't know. طيب. So involving the police is a very traumatic experience. Okay. Yes, it can be homicide. Yes, it can be some criminal activity, but majority of the time, I don't understand 100% why. Involvement of the police is kind of traumatic. Now, suicide, think about it from a psychiatrist or physician perspective. I do have a role in evaluation. Now, ما أعرف إذا أي أحد اشتغل معايا في الإي آر في الجامعي. People don't like me في الإي آر because I would never, ever discharge a patient. A child جاء على الإي آر suicidality. What I'm gonna do, هعمل الhistory. Okay, you don't have to take the detailed history. It would be nice if you do it, but history. الحاجة الثانية أعطي risk assessment. What are the chances of this child to commit suicide? And we document الأشياء. We do give treatment, but within the ER, there is really nothing much from a psychiatric perspective to do except admission. Now, I have 400 people in this room. How many of you can admit a patient للمستشفى? Now, so I'm pretty much calling us is useless. There's not a single guideline. But if you can go to American Academy of Pediatric, American Academy of Child and Adolescent, the Canadian guidelines. I don't care what guidelines you go by. ما في ولا guidelines تقول لك في suicidal patient. There's anything you can do except admitting the patient. The patient sometimes is not a high risk, okay, yet I have to admit the patient. I can't know a 15-year-old kid or a 13-year-old kid who's having suicidal thoughts or who tried to commit suicide, and I discharge this patient. So honestly, suicidality is a very dilemma. Now, this is ASK. Is anybody familiar with ASK? If you're not, you should. And that's a good opportunity to know. ASK is the NIMH, National Institute of Mental Health. It's one of the most reliable standard form of screening للsuicidal kids. So these are 4 questions. Any yes لهذه الأسئلة طيب حتكون a positive test. So a lot of times مو شرط تنادونا احنا في ال ER لما احد يكون مثلا suicidal, because تكون الستوري اتضاربت مع امها، كانت تبي تطلع البحر، الامها قالت لا والله حموت نفسي، راحت اخذت 3 حبات بنادول وجوكم على ال ER. So this is conditional suicidality. It's not necessarily somebody who wants to die. But that being said, these are the 4 questions. You get any of them yes, that's a positive test. You move to the 5th question. Are you having thoughts of killing yourself right now? Again, كثير منكم حيقولوا ايوه ممكن يقول لي كده عناد، او ممكن يقول لي كده just being obnoxious, okay, or عشان متضاربين مع اهلهم. I have to take this seriously. So this is somebody we should come and evaluate. That being said, حأجي, I'm going to do my risk assessment, tell you the chances, and most likely if she tried to do something, I will still need to admit, and I'll tell you why in a second. Now, I chose ask because ask is a quick, ياخد literally 3 minutes عشان يتعبى. But إذا أحد فيكم والله الطوارئ فاضية وما عندهم شيء, there are other tools. There is the Columbia University tool. There is this one جاية من حاجة اسمها KSAT. The reason I added these specifically علشان reliability حقتها عالية والsensitivity حقتها عالية وتعطينا a risk factor. So مرة مشغولين في الطوارئ, you might not wait for a child psychiatrist to come and you want to take a decision. This can give you an idea how bad the situation is and kind of direct what to do. هل الصوت مو واضح للجميع؟
No, it's go fine. It's fine.
Okay. So now, dilemma of a suicide case. I hate to say this. Suicide is not a quick fix that I can do, because one, majority of suicide attempts are actually accidents. Children's بالذات دول 13 14 اتضربت مع اخوانها, she had a relationship, she was in love, she broke up with a person. كل الدراما هذه حاخذ 6 حبات بنادول او اخذ 6 حبات digoxin. They don't know the difference between Panadol and digoxin with therapeutic with lethal index to medicine. So most of the time it's an accident. So لما يجي الناس يقولوا والله psychiatry مكبرين المواضيع, الpatient is not impulsive and it's attention seeking. حتى attention seeking, if they got the guts and the courage to do something, نخاف منهم because majority it's an accident. Now studies showed, and this is very important, إنه most of kids or adults حتى who committed suicide, they did have an encounter with the professional health worker. يعني إحنا شفناه مو معناها psychiatrist, شفناه معناها أحد في الطوارئ, pediatrician, medicine person. So it was seen within the system, and this is why it's important لما يجينا أحد في المستشفى نعمل screening, because a lot of time you can detect these people and see what can we do about them. Now, just for you to know, suicide contract does not hold. Suicide contract a lot of time you see في ER إنه أو حتى outside إن الطفل يقول إنه هو he's gonna contract for safety ومش عارف مين. Now, the suicide contract does not hold in court. You see a patient in ER and بعد كده يخرج لا قدر الله and they commit suicide. It does not hold in court. It doesn't really protect you. Guardian contract does not hold. What we do a lot of time في المستشفيات خاصة لما ما يكون عندنا admission, نخلي الأهل يوقعوا ونقول إنه إحنا حناخذ الطفل من هنا ويخرج من المستشفى وبعد كده حيروح يشوف أحد في مستشفى ثانية, or they promise he's going to be admitted, or they promise إنه بكرة حيجيبوه على الطوارئ. This is a joke, okay? So contract حق الأهل has no legal, medical, or ethical stand. It doesn't mean anything. The dilemma, I completely understand. ما عندنا seclusion area. فين ححط الطفل? I need to put a suicidal patient في غرفة ما فيها IV lines, ما فيها windows, ما فيها شو اسمه bed sheets, ما فيها حدايد, ما فيها إبر, ما فيها مش عارف مين. So seclusion areas ما هي موجودة. Trained staff, ما عندنا trained staff. أي suicidal patient, he has to be in a suicidal watch. You don't have the staff enough إنه واحد يقعد 24 hours بس يطل في البيشنت, and we definitely don't have an admission room. I'm sorry, I'm not that type of suicidal, but at least we can detect them. You can refer to us for clinic. We are helpful في حتة doing evaluation, and but not much in terms of management. Now, حاجة مرة مهمة لازم نفرق بينها ما بين suicidal patient and self-mutilation behavior. Earlier on, somebody talked about self-harm. Self-harm, self-mutilation is the same thing. Now, if somebody told me into شغالين emergency medicine pediatric, if you have never seen one of these, you really missed it because the list is مرة كتير عندنا حتة القطع. Did anyone see this in the ER أو في الأولاد مراهقين? Okay, so kids are really smart. So a lot of you that say yes, you see this a lot. Self-mutilation behavior, because a lot of time the family would come to the ER freaking out and the الطفل قاعد is cutting ولا burning ولا بيشدوا شعرهم. Self-mutilation behavior rarely is a suicidal. Now you'll be surprised. Somebody said في state. Now you'll be surprised. Actually, you have a lot of kids really bad cuts عندهم. Some of them are very sophisticated. ما حنلاقيها هنا, ممكن تلاقيها على a little bit فوق في حتات that are covered. Now it's not attention seeking. Now it's not female teenage. Now not Leishman syndrome. Like Leishman syndrome is a little bit completely different. The age group is a little bit different. I'll talk later on about Leishman syndrome. طيب, now لا, kids do this for frustration. يعني adults sometimes لما يعصبوا يروح رازع الباب ولا رامي حاجة كده بجو because they're very frustrated. So the mechanism of self-mutilation behavior, you cut because you're frustrated and upset. You do the cutting, you get some sense of relief, you feel a little bit relaxed. And the reason for relaxing, when you cut, endorphins are released, and an endorphin هذا يعطيك some sense of feeling better. So rarely it's attention seeking, and most of the time it's because of stress and anxiety. Borderline, very common, but remember, borderline does not get diagnosed before the age of 18. So انتم مو المفروض تشوف, مو المفروض diagnose borderline. You can see borderline trait. Now, child abuse, what is the most common kind of child abuse? This is one of the most typical MCQ question. Okay, so the most common, I have few names, Zoba, Rahab, the most common is neglect. Okay, that's by far the most common kind of child abuse. Neglect. It's not physical, it's not sexual, it's not emotional, it's actually neglect. Neglect is failure to providing the care اللي المفروض تتعطى للطفل. Now, again, child abuse يشبه suicidality is not a psychiatric emergency, it's a system emergency. Now, في جا patient, okay, and think again as a psychiatrist. أنا أشوف an anxiety, depression, PTSD, psychosis, autism, ADHD, I give medicine وأشوف المريض. لما يجيني طفل case of a child abuse في ER, what can I do? Am I going to give medicine? I can't give medicine because I cannot diagnose anything. Now, I write a report. Now, I write a report, I'm in my evaluation, you get upset because you want to discharge the patient. This is a mission. تخرجوا من البيت, we really want to discharge the patient. I'm not saying you're bad people, but again, you have limited bed, limited resources, you have people with life-threatening emergencies. So it's kind of emotional support. Ya Allah, Saleh, لا أشوفك. طيب, why would I give emotional support? This is one of the things that irritate us. Yeah. Why would I give him? How do I give emotional support? Okay, I don't know how to give emotional support. So, and here is the problem. It's the emotional support. A lot of people think we're gonna come and talk to the patient. So, yeah, we don't do that. Okay, psychologists, ايش يسووا؟ حتى psychologists, no emotional support. What they do, they they evaluate the situation. They help them through development of coping skill. What a DBT? DBT is for borderline personality, older people. And the thing with the child abuse حل حاجة واحدة, removing the child from the area اللي هو فيها. We talk about the report. The report is documentation to protect me, to protect the hospital, but how much we're helping the child. عندكم lines حقت protective services. حرام, they're doing a lot of work. It's still a baby step, but majority of the time you're discharging the child to the family. Okay. Very limited number يروح لحماية, very limited number يتاخذوا من الأهل. Okay. ما عندنا إحنا شو اسمه child protective services اللي remove the child from the family. We send the child to the family وبعد كده اللي بيصير sometimes في visitation من social worker, they make sure that he's doing okay, but you're putting the child again, which is really not the ideal situation. Now, what is your role لما تيجي child abuse cases? You need to suspect, okay? That's really the main thing. You need to be suspicion threshold عندكم مرة واطية. لما ألاقي multiple injuries, different stages or various stages of healing, failure to thrive, and you cannot justify it or explain why. History not consistent with the injury. MashaAllah, you're all well trained. You know the mechanism of a failure. لما الواحد يطيح and what kind of fracture they should be getting. لما يكون الفراكشر غريب of admitting team. طيب admitting team, who's the admitting team? طيب أمل يوسف, please حطي كده دائرة على السؤال هذا. I'll get back to you toward end of the lecture. Because who is the admitting team? لازم يكون في ownership to the patient. A psychiatry patient or a child في ER who is suicidal or who is abused, مين شو اسمه primary team. So we'll talk about this. Now, عندنا spiral genital areas injuries, inconsistent history, الأم تعطيني history, الأبو يعطيني history of academic failure, regression of milestones, كان عنده ما يسوي على نفسه بعدين صار يسوي على نفسه, some sexual act, if he's using words ما تستخدم, is عنده sexual gesture, this is really your threshold of, you know, suspecting something. Interviewing tips: if you ever suspected a sexual abuse or abuse in general, limit the number of professional caregivers. So if you are an intern or if you are junior resident, حتى senior resident, if you suspected that, please talk to the most senior person في الوقت هذا, هو اللي يعمل الانترفيو. Why? Now, children can be traumatized by some of the experience. What is more traumatizing, repeating it over and over and over. يجي الانترن ياخذ الهيستوري, وبعدين تيجي الريزيدنس, وبعدين يجي السينيور ريزيدنت, وبعدين يجي الكونسلتنت, بعدين يجي الشايلد بروتكتيف تيم, وبعد كده يجي البوليس. So do you imagine the number of times that child is repeating the story? This is one. Two, avoid leading questions. Now, a lot of these cases are forensic cases and it will go to the police. الباثولوجيست وحقون الناس اللي بيجمعوا specimen. Yeah. طيب avoid شو اسمه نسميها contaminated specimen. When you give a leading question to the child from a forensic perspective, you ruin the whole interview for the child, because لما نيجي نقول طيب بابا مسكنا هنا أو فين, this is a leading question. So one of the things that you should be trained to do, not to ask leading questions, because leading question in مثلا in different countries kind of dismiss the whole interview because you already gave the person and the child a name. فالطفل أول شيء حيقوله yes فلان, just because the name was repeated. So please be careful when you're interviewing. Now, the main thing that actually you would see in the ER is agitation. Agitation is very common. Now, agitation, كثير أحيانا تجينا المكالمات, والله the patient is agitated. And I don't know what agitation is, because I can be agitated. تكلموني الساعة 3 في الليل تقولوا لي ما أعرف إيش, I'm going to be agitated. So you have to be able to define what is agitation. Agitation is refusal to cooperate. نبي نعمل blood work وسوى لنا مشاكل. As a direct threat to self or other, be attacking nurses or attacking the doctors, or attacking himself بيعور نفسه. Is his purposeless movement, بيتحرك مرة كتير and he's agitated, like we see with autistic kid or severe mental retardation. Affective lability, بيبكي وبعدين يزعق. طيب irritability, intimidating behavior, طبعا هذه نشوفها في الأولاد الكبار. So once you define issue, what is agitation exactly, that would help you to kind of look into the cause of agitation. Is it metabolic disorder? Like somebody earlier on mentioned Dystonia syndrome, okay? Is it neurodevelopmental disorder, autism, mental retardation, substance abuse? Again, is it احنا عملنا cut off the pediatric age group? طيب the pediatric age group is 18. You will be seeing a lot of substance abuse. We're having ما حقول epidemic, but a lot of people are using أشياء زي crystal meth اللي بتسوي agitation, now delirium and confusion. Each one of these يفرق معايا في psychopharmacology اللي حاطيله إياه. So once you define the behavior and the cause of agitation, then you look into managing the patient. Behavior intervention, chemical restraint, physical restraint, these are the three main things that you work with. Now, as a pediatric residents and ER consultants, do you get training for behavior intervention, اللي هي de-escalation of agitated behavior? Is that part of your training? رائع، ما حضرت الكلاس، كل زملائك أخذوه. طيب. So behavior intervention, anybody works in the ER has to receive behavior intervention because people usually أصلاً agitated. So de-escalation to agitated behavior is part of the training. So I'm not going to go much into behavior intervention. I'll talk about chemical restraint and physical restraint. Now, drug use to behavior, to control a behavior, restrict patient freedom of movement, and it's not the standard treatment for medical psychiatric condition. Now, the standard, there is no specific pharmacological agent. يعني ما في guidelines 100% واضحة أي دواء, okay? Doctor, what's your point? Dr. Bandar, if you just clarify the question, I can answer you. A choice يعتمد على what are you seeing and what do you have في الطوارئ, okay? If I were you, familiarize yourself بالagent اللي موجود في المستشفى عندكم. Now, a choice يعتمد على severity of a target symptoms, the goal of the intervention. يعني هل أنا I just want to calm him down عشان أعرف أسحب منه مثلا blood work ولا عشان أعطيله medication. هل I want to underlying diagnosis أبى أعالجه إذا مثلا كان psychosis. Now the cause and choice يعني مثلا جاييني أحد بديليريا, okay? هتكلم عن options and classes of medication. I want to avoid إني أعطي بنزو. Okay, so بندر ما حأعطي بنزو if I'm suspecting delirium. I will avoid it. And بس إذا مثلا كان psychosis, I can give benzo. The three classes: antipsychotic, okay, benzodiazepine. ممكن نعطي both benzodiazepine and antipsychotic. For a reason or another, I notice ER people, they love antihistamine, diphenylhydramine. Diphenylhydramine is a good medicine, بالذات في الأطفال اللي هم مرة صغار. Do you actually give ketamine? Because ما في أي guidelines في الحياة تقول أعطوا كتامين. ketamine before procedures. طيب أحد تبوا تدخلوه ياخذ biopsy, but no. If somebody came across guidelines تتكلم على ketamine, yes, exactly, that's for anesthesia. We can give for sedation procedure. يعني some of the kids who are going to a procedure, they're super anxious, they want a little bit oozy, yes, but ما في for agitation ketamine ever, unless you have new guidelines that I'm not aware of. Now, dosage, they're very simple. As I said, familiarize yourself with the type of agent اللي عندكم. الانتيسايكوتيك احنا عندنا typical و atypical. haloperidol, sarazine. أكثر من أحد فيكم اتكلم على haloperidol. This is pretty much the first choice. بعد كده عندكم secondary agents اللي هي atypical, olanzapine and risperidol. Now, here is the tricky part. فاكرين لما قلت لكم choices? An agitated child. Think about somebody who's autistic. A lot of time, للأسف, some of them عندهم metabolic syndrome. They're extremely overweight. They're extremely agitated. It's not going to be cooperative إنكم تعطوا له الحبة في فمه وياخدها. So your choice of medicine لازم يكون في منه PO and IM. Okay. So مشكلة الريسبريدال ما في غير PO. Some people use Seroquel ما في غير PO. Valproic acid actually sometimes can be used, but it's only PO. Olanzapine في sprinkles تتحط في الفم, but again it's PO. So you always want to think of a medicine أقدر أعطيه IM وأقدر أعطيه PO. Now, ethically, a child بالذات إذا كان adolescent, I have to offer them PO medication قبل ما أعطيه IM. والله ال PO قال okay, that's fine, IM. Now, the guidelines تتكلم على 2 to 5 milligram PO IM. That being said, sometimes as low as 0.5 milligram is good enough في الأطفال. Sometimes you want to give prophylactic benzotropin, cogentin, 1 to 2 milligram, or you can give diphenylhydramine, 25 to 50 milligram. So that's the second choice. So عندنا الانتي عندنا الانتيهستامين, بعد كده benzotropin. You can use ariprazole, بس الاريبرازول PO ما عندك IV, ما عندك IM. You want something, because think about it, في الإي آر الدنيا مقلوبة ومش عارف مين, ما حتقدر تعطي always PO. تيجي على البنزوديازيبين, lorazepam is actually our favorite لأنه ما له metabolite. So إذا أعطيت 1 to 2 milligram PO Q1 hours, I can keep giving. طبعا لا تدخلوا في respiratory depression, but until they calm down, you can give it to them. The half-life حقته very reasonable, up to 10 to 18 hours. So this is really your choice. Now, أحد أعطى diazepam, that's not raw. You would never give Xanax لأنه it's a short half-life, but this is what you want to do. Yes, you can give clopramazepine, but I don't know which hospital has it. It's a very old atypical antipsychotic. Not a lot of hospital has it. أتوقع الصحة النفسية they do, so you can use that. Now, remember something very important: paradoxical reaction to antihistamine and benzodiazepine. One of the funniest things some doctors do, الأم تقول عندنا رحلة لما أعرف فين، حنقعد في الطيارة 10 ساعات ولا 8 ساعات. I need something to calm down the child. الدكتور يقول لها Benadryl, diphenylhydramine, awesome blossom. مشكلة البنادريل والبنزودايازepine في الأطفال sometimes يعطونا paradoxical reaction. So بدل ما يهدأ الطفل يصير عنده severe agitation, and it would be so hard to control them. And imagine قاعد مع أحد 8 سنين بس كنت أبغاه ينام and he's going crazy في الطيارة. paradoxical reaction is not dose dependent. Interestingly, مع smaller doses. يعني أحد يقول أعطيته بس 15 أو 20 diphenylhydramine. That is good to do the trick, and it's going to be not a good trick for the family. Physical restraint, always remember. Now, we hate physical restraint. As much as possible, we want to avoid it. A doctor has to give the order. لازم في restraint form تتعبى. The least restrictive, we have to make sure. مرة سخيفة لما أحط أحد في restraint وينجرح ولا يصير له scars, and you're really up and putting yourself to a lawsuit ضد المستشفى وضد the doctors. So you really have to be careful. كل restraint لها protocol. So always follow the techniques. Now في guidelines, في different like guidelines, American Academy of Child and Adolescent, على حسب العمر, how often do we renew it and how often do we keep them. So مثلا أطفال أقل من 9 سنوات, 1 hour, and then I would start or try to get them off the restraint. Now, and then different types of restraint. Somebody earlier on talked about Leishman syndrome. Leishman syndrome is an agitation, and a lot of it is towards self. Like يعودوا نفسهم, يعضوا نفسهم, يجرحوا. Severe autism برضو بيجوا بنفس المشكلة. Severe mental retardation sometimes. So sometimes you have to do the mitten restraint ونغطي أيديهم so they have no access to their body. اللي هنا الأولاني, the brown one, is the extremities, that you cover 4 extremities. And again, you have to be careful. It has to be padded. في really, really strict guidelines. And the reason for this, في حصلت كذا mortality على people who were restrained, وفي حصلت كذا side effect and مشاكل على when you're restrained. So really you want to avoid the restraint. That being said, a person who's restrained has to be on watch. أحد بيشوفه all the time. Now, again, الناس اللي يعمل restrain, yes, no prone position. الناس اللي بيعملوا restrain عشان أعمل medical procedure ما في أي evidence إنه this help, okay? And honestly, the evidence على physical restraint, evidence-based medicine practice is not the greatest. It should be avoided. The bottom line, you really want to avoid حتة physical restraints, and if you did it, you want to do the minimum. Neuroleptic malignant syndrome, everybody, I assume they should be aware, it's one of our major emergencies. Now, one of the best thing about our specialty, ما عندنا mortality. The highest mortality عندنا تيجي من حاجتين: anorexia nervosa, and alhamdulillah we don't see a lot of it. And الحاجة الثانية substance abuse. Other than that, ما عندنا mortality عالية. One for each extremity, yes. Now, symptoms include high fever, confusion, rigid, variable blood pressure, sweating. أحد عمره شاف neuroleptic malignant syndrome? It's very ugly, okay? It's kind of scary. And the bad thing about it, إنها تيجي من sometimes irregular dose. طيب يجي البيشنت بدأ إنه على أول مرة مثلا antipsychotic, and suddenly he's extremely rigid. Now, the problem with it إنه ممكن ندخل في شو اسمه renal failure عشان rhabdomyolysis. As of completion, I added this. You will see this patient in the ER, but usually they end up شو اسمه في ICU. المانجمنت دائما تيجي من medication. Okay, so first thing you want to remove the medication اللي بياخده نوقفه. Fluid resuscitation, correction of electrolyte. Consider ICU. It's not really consider ICU. Okay, actually you need to admit to ICU. Limited evidence on pharmacological agent, but the pharmacological agent اللي بيجوا severe muscle rigidity. نعطي bromocriptine, dopamine agonist, 2.5 to 5 milligram في 8 ساعات PO or NG, or dantrolene as a muscle relaxant, also Q6 hours, and benzodiazepine. That being said, the evidence حقهم مو أعلى شيء في الحياة. Sometimes you're going to have to start this management في ER, but eventually they have to go to the ICU because of the mortality اللي تكون عالية. Just for addition, if you want to know, if everything fails, you can do ECT. Anticholinergic ما في role إنه إحنا نعطي anticholinergic. شو اسمه cooling, yes, ممكن نعمل cooling, absolutely. Now, one of the things اللي الناس دايما تلخبط بينها neuroleptic malignant syndrome and serotonin syndrome مرة يشبهوا بعض. Okay, the only difference is your history. الهيستوري في serotonin you have a history. أحد كان على antidepressant, أحد كان على Prozac, Cipralex, that kind of medication. Neuroleptic عادة يكونوا أخذوا antipsychotic. Usually السيروتونين الدوز أعطيته اليوم أول جرعة بروزاك بعدها ب 12 ساعة 6 ساعات دخل في اللخبطة هذه. Neuroleptic usually take longer time. الاثنين يجوا بحرارة، الاثنين يجوا بتاكيكارديا، الاثنين يجوا في vital signs of normality. Now, very كده subtle difference between الاثنين. Neuroleptic malignant syndrome يجي ب complete rigidity of the body. Okay. Complete rigidity of the body حتلاقيه كله body. السيروتونين usually lower extremity. في النيوروليبتيك في hyperreflexia. في السيروتونين hyporeflexia. في clonus. النيوروليبتيك ما يكون في عادة clonus. So very يشبهوا بعض. Even for psychiatrists sometimes إحنا نلخبط بينهم. كتامين as a first line treatment of هذا. Now اللي حط لي شو اسمه عمار. Now, everybody can write anything. طيب الكتامين is really هذا. You always go by guidelines. There's a reason ليش إحنا في عندنا guidelines. عندنا حاجة اسمها evidence-based medicine practice. You can have an article that talk about ketamine. Ketamine is huge when it comes to talking about treatment of depression, but it has to make it to a guideline. Is it promising? It's promising, but it's not a guideline. أنا كده طلعت على اللينك اللي ترسل لي. أحد سألني كتب لي إنه ketamine can used in agitation. Clonidine can be used in agitation. Propranolol can be used. There's so many things, but it has to be guidelines. Now, yes.
Is it easy to detect the signs of hyperreflexia and hyperactive bowel sounds and the other clinical presentations to differentiate between both?
If you see one case of neuroleptic malignant syndrome, one case, you will never ever forget it. Okay. I didn't go كتير في حتة investigation. One of the cardinal signs في حتة NMS is CK. طيب. CK. طيب. في البدايات ما يكون عالي because انت you need to be catatonic and rigid for a very long time to break المسل وتدخل في rhabdomyolysis وتدخل في CK تكون عالية. So early في البداية it might be very similar to serotonin بس مثلا تعطي له 12 ساعة 24 hours you will have a CK تكون مرة عالية. So الاثنين يلخبطوا قلت لك even us as a professional sometimes الاثنين يدخلوا في بعض خاصة لو ما عندي good history. الشيء اللي مرة يفرق معايا الهيستوري لما تقول لي كان بياخد 1 2 3. Now the problem with the history something that you don't see أي حاجة تعطيني dopaminergic activity حتدخلني ممكن في NMS. One of these things drugs. الدراجز ترفع لي الدوبامين. Okay so واحد بياخد مثلا PCP وبعد كده في نفس الوقت بياخد antipsychotic حتى لو كانت الجرعة بياخدها طول حياته نفس الجرعة ما زودها that can get him into NMS. So something ما دائما ننتبه له في الهيستوري شو اسمه حتة الدراجز. So you should ask about drugs. Clonus can differentiate. Yes. Mydriasis ممكن تحصل شو اسمه في السيروتونين.
سيروتونين
Okay. ما تحصل عادة في ال NMS. The cardinal sign أحد قل لي حقيقي الفرق الرئيسي complete rigidity. It's really يجي very rigid البيشنت مو زي السيروتونين. Now, what are you going to see? Less likely for you to see NMS, but you're definitely going to see antipsychotic induced movement disorder. Now, عندنا acute وعندنا chronic Parkinsonism, acute akathisia, acute dystonia. من الكلام والchronic TD, chronic akathisia or tardive dyskinesia. What you're going to see من الكلام ده كله, because the rest احنا نشوفهم في العيادة, is acute dystonia. Now, acute dystonia والmotor dystonia من الcommon. في أحد عمره شاف أي واحدة من هذه؟
Yeah, the last week I saw one like oculogyric crisis.
Beautiful. طيب يلخبطوا في oculogyric crisis بإيش؟ What is the first differential diagnosis? Seizure. طيب؟
Yeah, exactly.
Seizure, صح? That's what they thought في ER?
Yeah, really.
Okay, so this is exactly the first thought اللي تيجي للأهل. طيب إنه الولد متشنج. This is the first thought اللي تيجي للناس اللي في ER. So really, if you ask me من هذول كلهم, you are more likely to see oculogyric crisis. And أحد يعرف أي medicine ما هو حق psychiatry يسوي oculogyric crisis?
Metoclopramide.
Something that's excellent. Okay. So metoclopramide, you would see oculogyric crisis. It's a very scary experience to the family. It's not nice to see it in ER because the kid looks very scary and the kid's haram is so scared. I don't know what Flazel is. What is Flazel? إيش الاسم الثاني له? Now, the treatment, benzotropin, cogentin, 0.02 milligram kg, maximum 1 milligram intramuscularly or intravenously. Diphenylhydramine, diazepam, كلهم can be used for a reason or another. ما أعرف ليش في الER they like diphenylhydramine. دائما they tend to use diphenylhydramine, but usually the first choice could be benzotropin. Usually they're very إيش يسموها? Very conservative في التريتمنت. يعني يعطوا diphenylhydramine في الER الدوز 25 ل 50 ملغ and then يرسل الطفل للبيت بالدايفينالهيدرامين. Cogentin give you a better thing. Now, tricky part, الديستونيا ممكن تيجي على diazepam, الديستونيا ممكن تيجي على benzotropin. مرة rarely, it's not something I would worry about غير البارادوكسيكال reaction with benzodiazepine, but it's something that can happen sometimes. Wow, you told me 45 minutes, خلصنا 45 minutes. Now I can take questions and we can have discussion if you have.
Yeah, thank you, Dr. Samra, for this very nice and very informative information. We learn a lot in very few minutes. Now we can open the questions for the coming 15 minutes. If you have any question related to the topics or question you need to just clarify in your practice, just Dr. Samra, she will be very happy to receive the questions.
طيب بما إنه عندنا وقت في part I wanted to add بعدين قلت I don't want it to make it heavy. Okay. One of the parts اللي I want you to think about is that إحنا قلنا pediatric age group is until 18. Okay. Stuff that you'll be seeing a lot في الأيام القادمة is intoxication or substance abuse. Everybody should be familiar في حاجة اسمها SIWA protocol. SIWA protocol is the evaluation of somebody who is using alcohol. طيب. So this is something لأنه ما نبغى ندخل في DT, ما نبغى ندخل في withdrawal seizure. So please don't be shy or not comfortable asking about substance abuse. Very common, very easily missed. So please always ask. When it comes to all drugs, كلهم ك-ER physician ما تهمكم. يهمكم two drugs. واحد opiates علشان المورتاليتي اللي معاها والalcohol. Everything else is manageable and it's not life-threatening except الاثنين اللي قلت عليهم opiate والalcohol.
There is one question here for you, Dr. Samra. They are asking about how to differentiate panic attack from other medical diseases.
طيب. It shouldn't be difficult to, okay, so السؤال الأول, I'm just trying to أفتح هنا حاجة new folder عشان أحفظ حاجة. I'm sorry for that, please. Just give me 1 second. Right. Now, لما تيجي, what are other diseases that you're thinking of? That's the first question you ask. Panic attack دائما تتلخبط مع إيش؟ إيش الأشياء اللي نلخبط فيها مع البانيك أتاك؟ Asthma ممكن because shortness of breath. Hyperthyroidism, MI. Exactly. طيب.
Exactly.
Most of the people اللي بيجوا. Now we're talking about older kids. Okay. Now الصغار مو مرة كتير يجيهم panic attack. يجيهم مثلا a little bit of hyperventilation. But you're talking about the older. It's so easy to rule out MI. Okay, because you put the EEG, هتلاقي فيه a little bit of tachycardia, but ما في other abnormalities. Now, الhistory دائما يعطي لك clue. If you do the TFT and if you do an EEG, so the first thing لما يجوني الناس مثلا أنا كسايكاتريست panic attack, the first thing I would do is an EEG. Okay, an EEG, then you're ruled out. So it's easy, reassurance. لو أعطيتهم في العيادة في الطوارئ benzodiazepine, they calm down right away, then you're good. So your key is investigation, EEG, and quick response to benzodiazepine. That will differentiate between the panic attack والهذا.
Dr. Samra, last month I have seen a patient who about like 80-year-old girl. They have like a psychological background in their home. There is a lot of like psychosocial problems at home, and she presented to the ER different times with like carpopedal spasm, and we find that she is hyperventilation. Do you think that hyperventilation is a part of her panic or anxiety disorders, or?
Okay. So panic attack is a very specific diagnosis. Panic attack is extreme, intense fear of death. طيب يعني الناس اللي يجوا على الاي ار ايش يقول لك؟ انا كنت احس بنفسي حموت، هو من جد يحسب انه عنده MI. Okay, so this is an anxiety, a panic attack. البانيك اتاك الناس يقول لك قعدت معاه 20 دقيقة ولا 15 دقيقة. Panic attack, it is reported انها قعدت 30 دقيقة, but you'll never see a psychiatrist يقول انه قعدت معاه 30 دقيقة. البانيك اتاك تقعد like 30 seconds. طيب لو طولت ممكن دقيقة ونص. Okay, and then it goes away. Sometimes it's not even triggered. Usually في history of an anxiety, but it's a very short. Now, الشاهد اللي انت بتقول عليه most probably it's severe anxiety attack. So لو تيجي للchild هذا in general هتلاقي انه في anxiety, less likely panic attack. هتلاقيها usually triggered by something. يعني مثلا الأهل اتخاصموا، الأهل صارت مضاربة, and then they got really
right.
angry.
صحيح.
هذا اللي صار؟
صحيح. Yeah, that's
Exactly. Now, this is also similar to what? Similar الفانسي نيم الجديد اللي طلعتوه ايش يسموها؟ السودو سيجر، ايش اسمها الجديد؟ none what؟ أحد يساعدني. anyway pseudo seizure هتلاقيها بتحصل مع also sometimes triggered okay يكون في anxiety يكون في stress في العيلة يكون في that kind of stuff okay so هذه كلها ما حتكون panic attack تكون most likely related to anxiety. أنا دكتور بندر ماني عارفة أفتح ال Q&A. Non-epileptic seizure. Thank you so much.
Yeah, non-epileptic seizures, exactly.
Thank you. Yes, that's the word you could have put which is very funny because you say it to remove the stigma from the patient, non-epileptic seizure or whatever. So, yeah, but it's usually related to anxiety. Yeah? Questions?
There is a question, Dr. Samra, they are asking about the use of haloperidol and benzodiazepine. They think that, do you think that benzodiazepine is more safer because of the QT prolongation, the side effect of the haloperidol?
Okay, now the question you should ask, why am I giving it? طيب, now عندي واحد لأنه ما هي شو اسمه ما هي one size fit all. طيب أنا لازم فاكر لما قلت the cause of agitation. The cause of agitation فرق لما أحد يكون مثلا question mark substance abuse أحد شو اسمه psychosis أحد autistic. Okay. Now, أحد autistic severe agitation, he's not a high risk للQTC prolongation. إيش الcut-off حق الQTC? Honestly, I don't know في الأطفال. Is it 450?
Yeah.
450. Less likely to see it. ما أعرف في أحد عمره شاف الأطفال دخلوا في QTC prolongation. QTC prolongation نشوفها عادة في ICU patient. ما هي ICU حتى ICU patient, older people, multiple comorbidity معاهم بس مو كتير في الأطفال. So I wouldn't worry about this.
And if he is a cardiac patient, do you recommend to be away from the haloperidol?
لا. طيب
No.
again
Okay.
what kind of cardiac patient طيب عندك أحد عنده atrial stenosis is ال ECG حقته كويسة no you have to think about لما أنا في ال ER it's a life saving أنا ما حأعطي haloperidol as a luxury أنا بعطي haloperidol because it's a disaster okay
excellent
بيعود نفسه بيعودني sometimes حتى ما أعرف إذا عنده allergy في أطفال عندهم allergy في patient عندهم allergy but to the best of my knowledge this is the medication I can give. Haloperidol versus benzodiazepine, you can give it benzodiazepine, but as I said, it's anti-anxiety. It will relax the patient if it's a little bit anxious. But severe agitation اللي بيضرب وبيعض وما احنا قادرين نمسكه وجو 4 من النيرسز يمسكوه والكلام ده كله, no, antipsychotic is your first line.
Okay, any other questions? There is a question, I think, what is the difference between neurosis and psychosis?
Okay, طيب this is just for the عشان عندنا وقت بس to you مو مرة أظن تفرق كتير, right? Now neurosis نتكلم على كل ال diseases اللي neurotic يعني نتكلم يعني حاعطيكم مثال depression. Do you think it's neurosis or psychosis? Neurosis, anxiety, neurosis, OCD, neurosis. Now الأشياء الثانية نتكلم على schizophrenia, psychosis, NOS. So when you start thinking about neurosis and psychosis, يعني مثلا medical students, medical physician, معظمهم neurotic. طيب مو شرط neurotic as a disease, but neurotic personality. You're obsessive, you're anxious, you're الاسم القديم زمان كانوا يقولوا type A personality. So this is when you're talking about neurosis. Neurosis أحد كتب هادي طيب they know إنهم they're sick. الكلمة اللي أنت قصدك فيها is insightful. طيب so they have the insight to the problem. Psychosis ما في insight. And this is very important لأنه when they consent the treatment, psychotic patient not always they can consent for treatment because they're شو اسمه ما هم insightful. So that's the difference between two. In ER, neurotic cases, you will see you're talking about depression, anxiety, panic attack, PTSD, الناس اللي اضطرابات ما بعد الصدمة. بس في الأطفال اكثر حتشوفوا سايكوسيس لانه بتشوفوا الاي اس دي والمنتال ريتارديشن، metabolic disorder, Prader-Willi، كل الاشياء هذه الميتابوليك.
Okay, one question, Dr. Samra. After the streptococcal throat infections, some of the patients in the pediatric, they can develop chorea. And I saw one cases in the ER, they develop, and they think one of the complications they can develop is like obsessive compulsive disorders in the future. Do you recommend when we diagnose that to refer for the psychiatrist for the complication that can happen?
طيب let me ask you this, what is the stand على زي ما رائد البانداز؟ طيب because panda is one of the most controversial diagnoses. طيب people kept their professional kept going back and forth and panda exists, does not exist. ايش اخر standard evidence based medicine practice في البانداز؟ Exactly. طيب, so we're still kind of wishy-washy about the pandas, and I'm not sure. Now, أحد عنده Korea, would you refer to us? For Korea, not really. For OCD, maybe. ما إن الشخص the best area هذه people who are neurodevelopmental. So somebody like Basma Al-Jabri, movement disorder, she would be the person who would deal with this.
Mm-hmm.
طيب, في سؤال هنا. Antipsychotic that can trigger a seizure in cases of autism ADHD. Do you recommend to cover with antiepileptic drug or do EEG before starting those antipsychotic? طيب, السؤال is very confusing لأنه عندك واحد عنده ADHD. Why would you give him antipsychotic? You would never give an ADHD patient antipsychotic. Antipsychotic is not treatment for ADHD. So السؤال, why would I give antipsychotic? This is one. Autism, yes. FDA approved للتريتمنت للأوتيزم agitation irritability أشياء كثيرة ريبرازول وريسبريدال. So now إذا ما عنده history of seizure, I don't have to do an EEG and I don't have to give prophylactic medication. Always remember you want to avoid polypharmacy. Now من الأدوية حقتنا كلها ما في شيء ينزل لنا الثريشولد حق السيجر غير الريسبريدال ودواء ثاني اسمه كلازابين. So إذا عندي واحد أوتستيك autism, about 40% of autistic kids يجي معاهم epilepsy or seizure. I want to avoid the risperidal. Risperidal does lower the threshold of a seizure, so I want to avoid it. بس لا, الحاجة الوحيدة اللي I can think prophylactically تعطيها is benzotropine and high doses of antipsychotic. But no, I would not do EEG and I would not start anti-epileptic medication.
Any more questions? I think, this is the most of the questions we have. You can see the question, Dr. Samra, right?
عفواً؟
You can see the questions, right?
والله شوف, هو الصراحة يعني الصفحات صارت مرة كثير. طيب, أنا شايفة الشات. طيب, بس I'm counting on you to see the question.
Yeah, I think.
علي كتب من الأشياء اللي قالها شوية. قال إنه you see a lot of practice, by the way, من psychology, من psychiatrists, adult psychiatrists, الريسبريدال يعطوه لل ADHD. طيب, there is no role in giving antipsychotic to an ADHD child. ما في أي guidelines في الحياة. طيب, تقول إنه نعطي antipsychotic ل ADHD kid. So, but it's a common practice.
Okay, I think this is most of the questions we have and the time is over. Really, Dr. Samra, you give us a very good bolus of information today. We are very pleased to have you today in our SAS and pediatric activity. We learn a lot today from you, and we like your way of presentations. Very nice and very smooth and very informative. Thanks also for Dr. Roa, Dr. Reem for their support, the logistic support for this seminar to be run. And inshallah, we will have next webinars, inshallah, will be more and more in the future for the pediatrics emergencies. Thank you. And if you have the last thing to say, Dr. Samra.
Thank you so much for the invitation. والله يجزاكم خير. ترى مو لازم يكون عندنا كورونا عشان تعزمونا. We can be useful sometimes. مو لازم تكون في
Thank you,
مصيبة.
Our pleasure.
It was a great talk.
Sorry?
It was a great talk, and it's our pleasure to have you.
Same
Without
here.
Corona.
الله معاكم and thanks a lot for the invitation. طيب I'm gonna check out but please give me a few seconds لأنه I want to copy and paste some of the questions because I can answer it later on على different في my Twitter. أبغى أسوي copy and paste للأسئلة. So if you just give me do not cancel هذا please.
Sure.
Because
Thank you, Dr. Bander. Thank you, Dr. Ru'a. And see you all tomorrow in our last webinar in the series EMS Heroes Battling COVID. See you inshallah.
إن شاء الله. شكرا جزيلا لكم جميعا. يعطيكم العافية وكل عام وأنتم بخير جميعا.
الجميع شكرا.
I'm having trouble hearing you.